I do want to thank you for letting me be here. Thank you to Hyundai for your rich support of our field over the years. It's very impressive. So let's talk about survivorship. And I'm going to shift gears out of basic science, and we're going to go to population science. So hopefully I can keep your attention here and sort of direct you towards the end game, the ultimate goal. So the title is Childhood Cancer Survivorship, the Consequences of Cure. And I'm going to talk largely out of the Childhood Cancer Survivor Study, of which I'm the principal investigator. So it is really one of the wonders of modern medicine, if you think about it, that if you go back 50 years, 20, maybe 30% of children were surviving their cancer, and now 80%, more than 80% will survive cancer, and that's fascinating. And as an epidemiologist, that's fascinating, because what that means is we now have a population of people that exist that never existed before, and we have to understand them. They're new. If you look at some of the survivorship statistics, it's pretty clear this is a growing population. In 2005, it was estimated there were 328,000 survivors. By 2013, 420,000 survivors of childhood cancer in the population in the United States, projected by 2020 to go over 500,000 survivors. So this is a growing population, but it's also an aging population. And so it's very important to understand both those facts. Finally, in my age group, those between 20 and 50 years of age in the United States, 1 in every 680 persons is a survivor of childhood cancer. That's fascinating. That means when you go to the mall or you go to the Nationals game tonight, you are in and around survivors of childhood cancer. They're everywhere. So here are the goals of this talk. First, I want to describe to you the need for a survivor cohort in the establishment of the Childhood Cancer Survivor Study. And then I'm going to show you what we've learned about long-term survivor outcomes. And I'm going to stay at 30,000 feet and talk about large population data as we hit what I think are the three most critical outcomes: long-term mortality, the risk for subsequent cancers, new and different cancers down the road, and then the risk for cardiac disease. And then after we talk about these risks, we can't stop there. We've got to talk about our response to those risks. So what is our research response? What's next? What do we do? And then finally, our responsibilities as pediatricians, as survivors, as advocates. What are our responsibilities once we have this knowledge? So here was the rationale for developing a survivor cohort now, almost 20 years ago. First, there are limitations in what a single hospital can do. A single hospital may have a lot of patients, but the ability to follow those patients over a long period of time is very difficult, especially when they become adults and they're no longer treated at pediatric institutions. So there's really been a lack of extended follow-up by institutions of their long-term survivors. It's been incomplete and passive follow-up. By creating a large cohort, you can overcome some of those weaknesses. So the Childhood Cancer Survivor Study was funded in 1994 by the NCI. It's a retrospective cohort of patients who were diagnosed between 1970 and 1986. They came from 26 children's hospitals all over the United States, and to be in the cohort, you had to be a 5-year survivor. All kinds of diagnosis, most of the main ones, leukemia, lymphoma, and otherwise. And what's very important for this cohort, we had to be able to ascertain detailed treatment information. So there were over 20,000 survivors from this era that were eligible for the cohort. Ultimately, 14,000 participated. That's a 70% participation rate. We currently have stored DNA on over 8,000 of them. And most importantly, and as of next month, we will complete our cohort expansion where we had 15,000 patients eligible in a new era, 1987 to 1999. And we've now enrolled over 10,000 of them into our cohort. So we now have an active cohort of over 22,000 survivors actively participating. I want to give you a slide on methodology because all of the results I'm going to show you hinge on how we approach these patients. So for this cohort, first of all, this is a survey-based outcome data cohort. They have all completed a baseline questionnaire and 5 follow-up surveys over the last 15 years. This is interview data, both survivors and parents. So if you were under 18, your parent completed this survey for you. Importantly for this cohort, treatment information is collected exquisitely. So we have cumulative dose information on 26 different chemotherapeutic agents. And we use a Radiation Physics Center at MD Anderson to calculate organ-specific dosimetry for those who received radiation. We have a repository for our buccal cell DNA. We have a pathology center where we confirm second cancers in this cohort and then collect second cancer tissue. And very importantly, we link with the National Death Index for our mortality studies. And then very importantly, we have a sibling cohort. You can't just define survivors. You have to define what normal is or what normal ought to be. And so we use their siblings as a comparison population. There's 26 sites participating across the country, and now with the addition of the sites that are in light blue, 4 new sites, which I'm happy to report. One of them is the Children's Hospital of Orange County with Dr. Cinder leading the way, and another is Lurie Children's Hospital, and Morris is here with us. We're adding those 2 hospitals into the cohort over the next couple of months. So this is a growing cohort. Here's the number of participating institutions. These are the main children's hospitals across the country. I've highlighted, well, actually didn't come out in red so well, but the one in your region is the Children's National Medical Center, among others. So where are these participants? Well, they're scattered all over the country. This is a remote cohort. This is 22,000, but they are all over the country. I like to say that the smartest survivor is this one, who's in Hawaii. But it's very difficult to follow a remote cohort. It has some challenges. But to date, this has been a high-yield study. So as of this month, we just published our 235th publication in the peer-reviewed literature on survivors of childhood cancer. So what was a black box of understanding 10 years ago has been enumerated by this study and others like it. So let's dig into the data. What do we know? What have we learned about survivors and their experience after that 5-year survivor point? And I have to say, as a clinician, that 5-year survivor point is special. And I don't know what you do in your clinics, but in ours, we throw confetti and we celebrate, and they transfer to survivorship clinic. It's a really, really big deal. But all this data is what happens after we throw the confetti, after we celebrate. And that's an important point. So this is the late mortality experience of 5-year survivors of childhood cancer. And we compare it to the general survival rates in the U.S. population. And you can see that by 25 years from diagnosis, 85% of these children who were survivors at 5 years are alive, but 15% are deceased. And this is very, very different than what you'd expect from the general population. Now, this is understandable. Through this period of time, there are late recurrences of cancer, or patients who were 5-year survivors but still had active cancer, and so are deceased during this time period. So death during this time period is largely attributable to recurrence of the primary cancer. But what we'd hope is beyond this point, beyond this 25-year point, cancer doesn't recur that far out, that these curves would flatten out. That would be the ideal scenario, and that at some point in time, our survivors become very much like the general population. But when we followed up in the study, we found the opposite is just the case. In fact, 30 and 35 years out, these survivors of childhood cancer are at a tremendously different risk for mortality than the general population. And so it's understanding this that's critically important. So I want to reframe mortality with this curve. It's a little complicated, but let me describe it to you, because if you understand this curve, you understand the entire field of cancer survivorship. This is the cause-specific mortality among aging survivors of childhood cancer. So this breaks mortality down into its specific causes. And the blue curve is the cumulative mortality attributable to recurrence or progression of the primary disease. And just as I was saying to you, with time, mortality due to recurrence of the primary disease levels off. It simply just doesn't happen after a certain period of time. The gray curve is death due to external causes. So these are accidents, injuries, trauma, suicide, relatively low. These are still 1% at 30 years out. But here's where the storyline is, this gold curve. This is death due to everything else, non-recurrence, non-external causes. These are medical causes of death. And what happens here is unexpected. Why, at 25 and 30 years, is there an inflection in this curve that all of a sudden, survivors who are still very young, they're in their 20s and 30s and 40s, are experiencing something that is causing their mortality rate to increase. And so this is my job. What is this? What's causing this? And what do we do about it? So let me break it down for you. So using standardized mortality ratios, this is just an observed ratio to observed to expected. The observed rate of cancer death, let me clarify. The observed rate of death in our population due to second malignant neoplasms, or SMNs, is 15 times the rate of cancer death in the general population. And the observed rate of death due to cardiac disease is 7 times that of the general population. So these two things, way down the road, 20 and 30 years down the road, are tremendous causes of morbidity and mortality in our population. So let's talk about that. That's mortality. Now let's talk about chronic disease, what underlies mortality. Before you have a fatal event, you obviously have to get sick. So let's talk about chronic health conditions. So we looked earlier this year at the cumulative incidence of chronic health conditions using the CTCAE criteria. And we limited to grades 3 through 5. So these are severe medical events, these are life-threatening medical events, and death. So this would be stroke, or heart attack, or heart failure, or renal failure requiring transplantation or at least intervention. And of course, no surprise, at 20 years of age, our survivors have a higher incidence of severe and life-threatening cumulative health conditions. 20% of survivors by age 20 compared to just 3% of survivors. But the real question is, what happens after that? Again, do they become just like everyone else, or does this rate in this gap between survivors and siblings continue to increase? And in fact, it very much does. And it takes a cohort to now be able to say something like this. We can describe the 50-year-old survivor of childhood cancer. So the 50-year-old survivor of childhood cancer has a cumulative incidence of 51%. Over half of them will have had a severe or life-threatening event by the time they're 50, which is fascinating and almost hard to wrap your mind around that. And so this gap widening between survivors and siblings so far out, that's very interesting. And it raises questions now about aging. And have we done something to these survivors to actually set on a whole different process of aging? So we're exploring this with a lot of interesting hypotheses, looking at telomere length and cellular senescence, which may set these survivors on an entirely different course for life based on their exposure to radiotherapy and chemotherapy. But something clinically it also tells you very interesting is that a 20-year-old survivor of childhood cancer has the same cumulative incidence of severe and life-threatening events as a 50-year-old sibling. And that makes sense with what I see clinically. When I walk into a room and I start looking at the laundry list of medical conditions that these survivors have accumulated, it's as if I'm in the room with an older patient. And so for the first time now, pediatricians and geriatricians need to start talking because we need to understand aging and normal aging so that we can better understand what is driving some of this. So one would say, but surely there's healthy survivors, and there absolutely are. But we also need to inform how the healthy survivor is doing, and a conditional cumulative incidence curve does that. In conditional cumulative incidence, you look at the cumulative incidence conditioned on the fact that they're healthy up to a certain point. So I've put the arrow here at age 45. So at age 45, a survivor who's never had a previous severe or life-threatening event, what is their risk going forward? So that'd be a relatively healthy survivor. Well, 1 in 5 of these healthy survivors at age 45 will have a severe life-threatening event or death within 10 years. Now the next question is, how does that compare to the general population? Same curve. 1 in 14 of healthy siblings at age 45 will have an event. So even those who are healthy or have avoided these chronic conditions, there's something underlying, something different going on. Where are these problems? Again, when you look at even up to the 50-year-old survivors, what's driving this are new malignancies and cardiac disease. So let's talk about those a little bit. So let's talk about second cancers. Down the road, what happens? This is a cumulative incidence curve for the risk of second neoplasms in our population. And let me clarify the definition here. The cumulative incidence of second malignancies, so these are malignant invasive cancers, at 30 years of age is 11%. 30 years from diagnosis is 11%. And that's this curve right here. But if you include benign meningiomas, and if you include non-melanoma skin cancer, and by that I use second neoplasm, 22% who are 30 years down the road will have had a second cancer. So 22%, 1 in 5 of our survivors have now experienced a subsequent neoplasm within 30 years of diagnosis. So maybe one of the most important of these subsequent cancers is the risk for breast cancer in women who are treated with chest radiation. This is our data, again, from our cohort, looking at the risk of breast cancer after chest radiation. By age 40, 12% of our radiated females have had breast cancer, and by age 50, that number is 30%. Again, almost hard to wrap your mind around, that 1 in 3 women who received chest radiation as a child will have breast cancer by age 50. So specifically, Hodgkin's lymphoma survivors are those at greatest at risk. They've had chest-directed radiotherapy in many cases, and there are other survivors who've had chest radiation, maybe for metastatic bone tumors or Wilms tumors, for example. How do their risks compare? Well, by age 40, Hodgkin's lymphoma survivor, 15%. But by age 50, a Hodgkin's survivor who's received chest radiation, risk for breast cancer, 35%. More importantly, how does that compare to the general population? If you use SEER to get an idea of the risk in the general population, 4%. And maybe the comparison you'd really want to know is, how does this compare to women with a known genetic risk for breast cancer or BRCA1 mutation? Well, Haya Moskowitz did this study and published it earlier this year. And if you look at BRCA1 carriers, 31% by age 50. So our survivors of childhood cancer who've received chest radiation are similar to that of the BRCA1 population, a very, very high-risk group. Now, with this kind of cohort, you can go deeper than this. It's important to report more than just cumulative incidence. We've got to understand why. And when you have specific dosimetry, as we do, you're able to get into the details and to dose-response relationships. So here's the dose-risk relationship for tissue-specific radiation exposure in breast cancer. So we know the radiation exposure for all of our survivors, and that allows us to create a curve that looks like this. Dose to the breast up to 50 gray, And this is the odds ratio, or the risk for developing breast cancer. And you can see that there's a linear relationship between increasing dose of radiation to the breast and increasing risk for breast cancer, such that there's an 11-fold increased risk for women who've had 40 gray of chest radiation. And this is a linear dose response. And what's important about this, what this tells us is, now how do we act on this? If there's a linear dose response, then reducing radiation to the chest ought to reduce the risk for breast cancer. So it's very clear with upfront therapy, when you see this kind of data, that we have to change upfront therapy in a way that can reduce risk. So this identifies the need to reduce radiotherapy during primary cancer treatment. But here's what's very interesting is you start following these survivors now through their 40s and 50s. Those who survive a first cancer remain at risk for another cancer. So they've had their primary cancer, they've now survived a subsequent neoplasm, and they're at risk for third and fourth malignancies. And so with this aging cohort, here's the pattern. This is a little complicated, but let me try to break it down for you. This is the risk for multiple subsequent neoplasms. And SN1 is the time of subsequent neoplasm number 1, and that's time 0 right here. So everyone right here, this is our population who've had one subsequent neoplasm. By 10 years from the diagnosis of the first subsequent neoplasm, 33% of those who had SN1 have now developed SN2. And by 20 years, almost 50% of those who've had SN1 and survived have now had a second subsequent neoplasm, the third cancer in their lifetime. So as these survivors are aging, we are seeing this very much like an epidemic. This is multiple cancers piling up. So here's a pattern. This is breast cancer as an SN1. So looking at our study, we identified there were 176 women who had breast cancer as their very first subsequent neoplasm, and then look what happened to them. 37 of them had a second breast cancer, a subsequent neoplasm that was a breast cancer. 2 had a third breast cancer. Of the 176 who had had breast cancer as SN1, 2 had a soft tissue sarcoma. 1 went on to have thyroid cancer. So you begin to see these developing patterns that are very important, and we have to begin to explain. So let's shift from second cancers to heart disease, and we'll talk for just a minute on heart disease. Patients who are exposed to anthracycline chemotherapy or chest-directed radiotherapy have an increased risk for heart disease, and we published recently what that risk is. This is the cumulative incidence of heart failure. This is CTCAE grade 3 through 5 heart failure by the time a survivor is 45 years of age. And so the gray curve here is for siblings, and the black curve immediately underneath it are survivors who had no radiation or no anthracyclines. But the risk is for those who have had radiation or anthracycline treatment. 11.8% have developed heart failure by 45 years of age, and 6.8% of those who've had anthracyclines alone. And this incidence is rising with time. And here are the risks. Heart failure, 10-fold risk compared to the general population. Heart attack, 5-fold risk. This is in patients beyond 35 years of age. Stroke, 6-fold risk. Joint replacement, 2-fold risk. Renal failure, 6-fold risk. So again, it's not enough just to describe the cumulative incidence of this disease. We have to go deeper, because what's happening to our survivors is not just a result of their therapy. Now they're aging, and they're taking on water. They're taking on additional risks. So traditional cardiovascular risk factors, they're becoming obese, they're developing hypertension, they're developing diabetes. How is this compounding the risk, or is it compounding the risk? Perhaps those things are nothing compared to the primary injury they received from radiation and anthracyclines, but we have to know the answer, because the answer changes how we care for patients. So we looked at modifiable risk factors and major cardiac events. And we wanted to evaluate the relative contribution to the development of CHF of these additional modifiable cardiovascular risk factors on top of the therapy that they had previously. So we did longitudinal evaluation over 10,000 survivors and wanted to ask the question, is the risk simply additive? Does 1 + 1 = 2? Radiation as a child plus then, or anthracyclines as a child plus then obesity as an adult. Is that 1 + 1 = 2? Are they twice as likely to have heart failure? So the first group we looked at were patients who had hypertension, but no previous anthracycline therapy. And their risk for heart failure was 34 times that of patients who had no hypertension and no anthracycline therapy. We looked at a population who had anthracyclines, but no hypertension, and their risk was 8-fold a healthy group, 8-fold the risk of a healthy group. But the real question at hand was, what about the survivor who had anthracyclines and then developed hypertension over time? What happened to them? Their risk, 88-fold. 88 times the risk of a healthy population, and very different from those other two groups. And so the hypertension potentiates anthracycline-associated risk for heart failure. And the same is true for the other traditional cardiovascular risk factors. Hypertension happens to be the strongest one. So this changes what we do in clinic. We go to clinic now, and it is critically important that we teach about healthy lifestyle, heart-healthy diet, exercise, and all the more for our survivors than even for us, because 1 + 1 doesn't equal 2. 1 + 1 equals 3 or 5 or 6. The risk increases multiplicatively. So fortunately, we've taken this knowledge, we, and I mean the broader community, and we now have a set of long-term follow-up guidelines. And in fact, I should note that the most recent guidelines were released just yesterday, version 4.0. And these guidelines have been disseminated by the Children's Oncology Group, and they tell us all how to use this data to practice with our survivors and how to take care of them. So I'm just going to give you an example. Here's screening recommendations based on the COG guidelines for someone who's had chest-directed radiotherapy or anthracyclines. And that requires periodic evaluation and a detailed yearly history. An EKG, baseline evaluation, and then two-dimensional echocardiogram for evaluation of systolic function. For some survivors, that's annually, and for others, it's every 5 years. It depends on the age they were treated, the history of chest radiation, and the cumulative dose of anthracyclines. So fantastic, we've got guidelines, and now we know how to take care of these patients, at least a prescription for taking care of them. But again, here's another problem. We have the guidelines, but they're not being used. This is a report by Paul Nathan a number of years ago now, looking at the prevalence of screening. And these bars are the number of patients who received the screening test. And I've circled echocardiogram. I just prescribed it to you, showed you it's in the guidelines. And yet, among survivors who are in a cancer center, of all places, only 50% got their echocardiogram. And if a survivor was not in a cancer center, but out in community care, being cared for by their general practitioner, only 22% received their screening echocardiogram. So there's a gap. There's a gap in our knowledge that we're not passing on, we're not disseminating to survivors and to the community. So if there's a gap, what's our response? We have to respond. There's got to be a response. So the research response is this. There's a need, an absolute need for randomized intervention trials to improve early detection and prevention. And I'm going to give you a couple of examples, but our field now needs to pollinate. We've got to be doing these more and more. One is breast cancer detection. I've shown you the data. You've seen the risk. There's now currently within CCSS, the Childhood Cancer Survivor Study, a randomized trial looking at ways to improve breast cancer detection. It's called the EMPOWER study. And Kevin Effinger from Sloan Kettering wrote a very large R01 to use the CCSS population to perform the EMPOWER study. And here is his recruitment brochure. Discuss getting screened for breast cancer. Survivors who are on the study get this card. And the randomization of over 330 women is to an intervention group and an attention control. And in this case, the attention control gets the mailed generic newsletter along with this card and general phone interview a few weeks later. But the intervention population gets tailored information telling them about their specific therapy, their specific risks, plus at 2 weeks a telephone-delivered brief interview by a nurse practitioner that's then calling and talking to the survivor and going through their risks and their understanding of their therapy. And so the primary aim is to determine the efficacy of just these tailored print materials and brief motivational interview on mammogram screening. Now this study is still ongoing, but I can tell you now that the rate is almost double in the intervention arm. So what is a very simple intervention? Doubling the rate of screening for breast cancer. Fascinating. Let me pick another one, because this one's interesting. Skin cancer risk. Survivors at a 3-fold increased risk for melanoma, and they're at a 40-fold increased risk for non-melanoma skin cancer. An investigator, Alan Geller from Harvard, recently funded an R01 to look within our population at skin cancer detection. The study is called the Ask About Skin Cancer study. And this is very interesting in that he's the first one to use teledermatology in survivors of childhood cancer. The goal of the study is to improve rates of skin examination and receipt of a full-body skin exam by a care provider at 12 and 18 months. And he's doing this in a 3-arm randomized trial, where the Arm 1 receiving web-based and print material, again very simple, plus text messaging. Arm 2, they're engaging the physician. But Arm 3, the survivors will be receiving a dermoscopic lens that will attach to their cell phone, to their smartphone, to allow them, if they have a nodule or a site on their skin that they're concerned about, to then take a picture, send it to the study dermatologist, and talk with the dermatologist. And the idea is that Arm 2 and Arm 3, and particularly Arm 3, ought to increase the rate not only of screening, but detection. So a good example of using technology. So what other responses? Where are the trials? Where are the intervention trials for hypertension, obesity, smoking? We need them. It's a gap in the field. Secondly, our response has to be to begin to understand genetic risk. When I showed you those patients with multiple cancers, you had to be thinking, is there something different about them genetically? We have to understand that. So we're collaborating with the NCI, particularly with the Division of Cancer Epidemiology and Genetics, and Steve Shannick, and we've performed genome-wide association testing on 6,000 of our survivors, and we're looking at the risk for subsequent cancers in that population, and hopefully we'll be able to crack open the code for understanding if there's a genetic predisposition for some of these patients. Thirdly, the use of technology. It's 2014. We need to be thinking about new ways to communicate. This man changed our lives. Most of us have a smartphone within 3 feet of our body as we speak. 91% of smartphone owners keep the phones within 3 feet of their body 24 hours a day. That's fascinating, especially when you think we've got a cohort of 22,000 that are spread out all over the country, and we're communicating with them by paper and pencil and telephone? Really? It's time to start using this. So look what you can do with a smartphone. Sensor technology is going ballistic. You can hook up a blood pressure cuff to a smartphone. We could get daily blood pressure measurements. You can do an EKG with a smartphone. The special cover lets you put your hands on the back. You can do an EKG. We can have your weight daily by smartphone. You can put your Fitbit, connect, and download data. We could have activity data. We can stop asking participants, hey, are you active? We can download their Fitbit data and know that they're active. So technology is changing everything, and this is a real game changer, wearable devices. If you have permanently wearable devices, why wouldn't we want this information? So finally, let's close with responsibility, and I'm sorry these slides aren't showing up very well. When we think about responsibility to our survivors, in the center here is cancer treatment morbidity and the risk for morbidity. That's what this talk was about. All around it are the things we need to think about in regard to responsibility. And let's talk about, first of all, provider responsibility. Provider responsibility, survivorship education and training. Sadly enough, I hate to say this, but in my own institution, just last week, I saw a survivor in clinic who for 6 years, while on a frontline trial, had their hearing testing on cue every year. Perfect. Once the trial was over, the treating physician forgot to continue to check hearing for cisplatin-related toxicity. 4 years later, the survivor shows up in my door, deaf in one ear. When? When did this happen? How did it happen? It happens, and it makes sense because in primary active clinics, we're thinking about tumor, we're looking at the MRI. We want to go, the MRI is clean and move on. See you in a year. But we can't do that. We got to be in the mindset of survivorship really early on so we can be detecting these events in survivors. Secondly, survivorship experience. We have to be thinking about that. We have to be thinking about our practice styles, providers. We have to think about perceptions regarding preventative care. That's not cool. When you're an active cancer doctor and you're in the ICU and you're taking care of sick kids, you're not thinking about prevention, but you have to be thinking about prevention. When I show you data about heart disease and the risk for hypertension and obesity, multiplying the risk for heart failure, we have to be thinking about prevention early on. We have to think about access to survivorship resources and then knowledge and access to individual survivor health history. Those have to be available and readily available for the survivor. Next, what are the responsibilities of the healthcare system? This is not my area of expertise, but these areas are critically important. Financing and payment possibilities and policies and how they impact the survivor. We have a paper under review now looking at the ACA and what is the impact on survivors. Organization and affiliation of providers. Data systems and information for sharing and how EMR may change our ability to provide information. Models of survivorship care, insurance coverage, and importantly, community resources in advocacy activity. But then finally, what's the responsibility of the patient? And this is hard. Educated self-advocate. Boy, that sounds good. Obviously, I wish every survivor were a self-advocate, but what I know is I have to teach them how to be a self-advocate. That is my job. I, as their advocate, want to teach them to be a self-advocate and then to have around them peers who are advocates, family who are advocates. Healthy lifestyle. We've got to talk again about prevention and healthy lifestyle and about preventative care. So I can't close with Harry Potter. I'm going to close with Van Gogh. In 1890, in the south of France, Vincent van Gogh had his first chronic health condition, and he was institutionalized, put in a mental institution. Whether it was epilepsy or seizures or depression, it's not really clear. But this first chronic health condition for him was very much like a death. And while he was institutionalized, he painted this. This is the resurrection of Lazarus. And if you look really closely at the painting and at the man in the tomb, guess what? It's him. It's a self-portrait. It felt like a death to him, this chronic disease. Yet there's hope. Outside of the tomb, there's a sun, a happy day, hopefully looking forward, and friends coming in to pull them out and to help them walk and to help them overcome the chronic condition. And that's our role, isn't it? As researchers and as friends, as physicians, to step in to this patient population with a tremendous chronic condition burden and to help them move forward. So I want to close by reminding you that the Childhood Cancer Survivor Study is an NCI-funded resource and has been funded by the NCI for 20 years. We've had tremendous support from them, and that this is an open resource. This is not a closed group of investigators. This is for any investigator interested in looking into survivorship outcomes. And so I thank you for the opportunity to talk, and look forward to questions maybe later in the day.